Dr. Khalaf. So,
yes, sir.
I'm now in Houston. You're in Houston, right?
In Houston, Texas, yes, sir.
Well, thank you very much for your time. We want to talk to you about, well, many heart disease, but maybe people just know about heart attack.
Yeah.
But that
absolutely.
it's actually more than that. I mean, we have many heart problem, and then raising an awareness will make people to know how to prevent and to prevent the complication of heart disease.
Yeah, no, thank you, Doc. Thanks for having me on. First of all, it's a pleasure to be here talking with you all. And I just want to tell you, I really admire your work, and I admire the work of your team. And when I see some of these videos that you guys are making, that's very heartfelt and very emotional. And I think that you guys have a lot more humanity in your medicine than we do over here in the West. I think we've sort of lost that, to be honest. I really do. And so when I see some of y'all's content in your videos, and it really makes me happy, and it inspires us, honestly. So keep up the great work. When it comes to heart disease, this is what I tell people. Nobody cares about their heart until it's a problem. It's one of those things that it's so, it's there, right? Everyone knows they have a heart, but they don't think about it. And then the second that it occurs where either someone's had a myocardial infarction or someone in their family's had a heart attack, then they're like, that's the only thing they can think about. So it's very interesting about the heart. And so I think preventative care is very, very important. I use a lot of the coronary CT angiogram in my practice. I would like to know what all of my patients' calcium scores are at some point throughout, me taking care of them, because I want to know. I want to be able to know, what is the risk of their heart attack in the future? How aggressive do I need to be with their lipid management? So preventative care is key. As far as the vascular stuff goes, Doc, honestly, I did some vascular in my training, but here in the West, when we do interventional cardiology, most of it's focused on the heart. We do, mainly PCIs and structural heart disease and things like that. The vascular surgeons in this country tend to dominate that field of vascular care, peripheral vascular disease. But it was something that I was very drawn to, and I actually enjoy it more than the coronary arteries. It's just, part of the different procedures I do. I think I like dealing more with big arteries as opposed to small arteries. They're very sensitive, these damn coronaries,
Yeah. And they keep beating. I mean, if you're doing PCR, you can see that heart beating. But if you're doing a vascular peripheral disease, well, it's actually, they stand still. It's different thing.
Absolutely. For sure.
By the way, I interested with what you said that about when you checking about your patient, you checking coronary calcium score, and then you're checking about their cholesterol level. I mean, do the patient in USA there, they think that, why do you check everything else? I mean, Indonesia, they often say that I don't need to check up because I feel that I'm really healthy. I mean, I don't have symptoms, and then I think I'm okay. Do you have same thing there?
We have, what we have, Doc, is we have a spectrum. We have a group of patients that are obsessive about it, and then we have a group of patients that could care less about it. And so it's very interesting. Here, I can't pinpoint how people think in this country. It's very interesting. But more often than not, I would say more often than not, we end up finding ourselves with patients right in the middle. Some people, they want to know everything about them. They want to have their cholesterol checked every 3 months. I tell them, I don't want to check your cholesterol every 3 months. That's too much. I don't want to do that. Maybe every 6 months, it's like, it's not necessary. But then you have other people who, they can't even show up to get their labs done. So you just get a variety of people.
Yeah. I get your point. So there is a patient that they're maybe too obsessive about their things, and then they check it too much. And there are people just about maybe careless, and then they don't need to check anything. They said that I'm okay. Okay, we have that too, that problem here. Okay, so actually in Indonesia, we have a problem of obesity. Can you see that in our country? Well, actually, we are thinking that maybe many people that maybe suffer about malnutrition, but on the other hand, people with obesity is rising. I mean, every years there are many people that turn out obesity. So what happened in your country? I mean, it's that major risk factors as well.
As everybody knows, the United States, the obesity in the United States is a pandemic. Okay, I mean, it's beyond proportion, and it's happening all across the country too. All across the world, not just in the U.S. But for whatever reason, in the U.S. it happened first, and I can tell you exactly why. Our food system is actually corrupted. What do I mean by that? I mean that corporate greed led to the development of a lot of these foods that we put in our mouths and in our children's mouths that should have never been allowed to become legal. Take saturated fats, for example. I eat fried foods. Yes. I'm sure you eat some fried foods.
Yeah.
Our patients definitely eat fried foods. Did you know that the frying oil that we use for fried foods, it actually has to go through a chemical process of hydrogenation to where it's not a naturally occurring substance? I mean, we literally take oil, make it saturated fat, and then fry our foods in it. And we know it's killing us. It's not like a secret. We know it, but we still do it. And so I think that a lot of the candy bars and the cereals and the saturated fats and just all these sort of foods that have been introduced into the wild, that the consumer just sort of put this trust in the FDA or in the, who's ever managing this thing. And just because it's available on HEB or in our grocery store must mean that, wow, it must be safe to consume. When in reality, I think that's very far from the truth. And so a lot of my patients, whenever they have had heart attacks, they always ask me, well, what do I eat? And then I tell them, I said, look, I'm not a nutritionist. I struggle with weight myself. I said, I'm not going to sit here and write down for you every little, breakfast, lunch, and dinner you're supposed to eat. I tell them it's very simple. And I think you guys would appreciate this because you guys are very religious and spiritual, which everybody should be. There are two kinds of food, man's food and God's food. If it's natural, if it's growing, God gave it to us, that should be safe to consume. If you look at the back of the box and it's got a full set of ingredients like the organic chemistry set, you should probably avoid it.
So yeah, that's very wise because I think maybe that industry, they need consumer, but I mean, the consumer still need it. I mean, so they buy it and then, very, that's many of at first, advertising content about that. You don't think about many sweet drink, with the, and then, it's very, very sweet there, very much sugar in it. And then it's make people like bigger and bigger. And in Indonesia, they think in Hollywood, in USA, they all six pack like in the film, like in the movie. I mean, so they don't think that obesity is still a big problem there. So it's still a problem.
It's a ginormous problem, and it's only getting worse. I mean, it's hard to control at this stage. Childhood obesity and childhood diabetes is at an all-time high. It's just climbing.
What do you think about tobacco use?
About what, Doc? Sorry?
Tobacco use, smoking.
Oh, tobacco use. Yeah. Same. No, the same concept. Whenever the tobacco industry came out and it's very funny. Whenever people started to realize, hey, this isn't good for you. Doctors used to smoke. Doctors would literally be doing procedures and smoking at the same time. I mean, it's unbelievable. People would smoke. Remember when in the airplane, people would just be smoking in the airplane? They used to have, I don't know if you guys remember this, but when I was a kid, you go on an airplane, there's ashtrays in the airplane. So everybody's just smoking and nobody really cared too much about the health effects. And then you had the tobacco industry testifying before Congress, telling people, it's okay. It's not bad for you. It's just complete corruption again, like we talked about. It's terrible. Tobacco use is terrible. It creates just a giant inflammatory response. And we all know that inflammation is the precursor to atherosclerosis. So it's not rocket science anymore. I mean, it's the same thing with the food. People do it. They know it's bad for them, but they do it anyway.
I got a patient, maybe 3 months or three months ago, I think. So it's very young, 30 years old. And it's already get 3 stents and coronary arteries, and then no hypertension. He was not obese, and no hyperlipidemia. Just smoking.
Just smoking. Just smoking. It's a big one. And the other thing too, Doc, is that people, you know, you got that 30-year-old that had major disease from smoking, but then you have another 30-year-old that has clean coronaries. So everybody's body reacts differently to the insult, if you will, as well. And it's hard to predict.
Yeah. They think because of their grandfather still live now. I mean, my grandpa is still 80 years old and then he still smoke and then he's okay. So I will smoke as well.
Sure.
Yeah. The thing about that, but yeah, you already make it clear that it's actually your body respond with every insult and then it's different. I mean, and there is a genetic factor as well. So yes. By the way, so we will actually have a World Heart Day in September, and then I don't know. I mean, we now have the theme use heart to connect. That's why I want to talk with you to have a new perspective. I mean, what happened in USA? I think USA is you have educated people. I mean, more socially maybe. Well, they have actually many information about that, about heart disease. But what the challenge there? I mean, why heart disease is still #1 killer in USA?
Because again, people do whatever they want. There's too much freedom here in terms of their ability to just not hold themselves accountable. And again, a lot of people don't care about their health. That's just the bottom line. A lot of people just don't understand that health is all we have. Without your health, you can't function. I mean, so the average person just doesn't get that until, unfortunately, it's too late, or it happens to them, or it happens to one of their family members. And so that's why, everyone's talking about, this vaccine passport, right?
Oh, yes,
COVID,
yes,
right?
yes.
You need to have a vaccine passport. You know what I think we should have? A coronary CTA passport. You know what I'm saying? If we really cared, right? It's because if humankind really, really, truly cared that much about people's unfortunate mortality, and cardiovascular disease has been the ultimate killer for generations. You know what I'm saying? It's like, why is there not so much emphasis placed on worrying about your heart? And so I just think it's interesting when you think about stuff like that.
Well, actually, it's preventable. I mean, as a disease, you can prevent it. And I have read American Heart Association statement that if you already 20 years old, you actually have your cardiac checkup, just like your cholesterol level and your blood pressure measured on. Because I think it's actually, it's a simple thing to do.
So let me tell you about me, because this is very interesting. I have a coronary calcium score of 26. I am 38 years old.
Oh,
I am in the 90th percentile for men my age. That means that only 10% of men my age have a score worse than me, right? Yes. And I'm a plumber, right? Yeah. So then I'm like, well, what do I do? I mean, I don't have any obstructive lesions, but I definitely have the beginning of atherosclerotic plaque in my heart. My father, God bless him, he's had emergency open heart surgery before. Oh. We have familial hypertriglyceridemia in my family. I take phenylfibrates and I take a baby aspirin a day. Thank goodness my blood pressure is under control. I don't have diabetes. I try and work out. And I try and eat right. So what else can I do? That's it. It's just all about prevention. So I'm actually my own patient. I treat myself. You see?
Wow.
So the way I'm trying to prevent cardiovascular disease in myself, I want to do the same thing in others.
Wow, thank you for being honest and then sharing this. You're awesome. Course. I mean, you're a real story that you can prevent that. And if you find out that you have a coronary heart disease, I mean, in the early stage, and then you can, it's actually easier to treat.
Yeah.
What do you choose? I mean, you choose to take a small pill or emergency bypass surgery. Yeah, it's clear.
Exactly. For sure.
Yeah. Okay. Wow. I just knew it. Okay. So, I think that's the same in Indonesia. I think maybe most of the people not really know. That was my motivation to give awareness and information, education, because even in people that I think have a good education, they don't really know about the heart disease. And then so that is my mission, and I really want to have them prevented from heart disease.
Yeah,
So,
me and you both, Doc. I mean, but it's a hard pill to make people swallow, because not only, education is one aspect of it, like we talked about, which is what you and I are trying to do. You and I are trying to take this aspect of social media and the internet and try to educate the public so that people can understand what's going on, as opposed to just only being educated when you come to see me in our office, right? Isn't that what we're trying to do?
Yes.
But at the end of the day, too, that's only one part of it. If the people are not willing to accept it, there's a lot of people that don't want to know this information, or they don't care, then you can't force it on them. But all we can do is try, right?
Yes. Especially, we both interventional cardiologists, and then we still have preventional thinking. I mean, we just not to put a stand in people's.
Right. No. You know, Doc, you know what I tell people, and I mean this. I mean this from the bottom of my heart. I tell everybody, my job is not to poke you. I don't want to do a procedure on you. I hate doing procedures. I mean, I love doing procedures because it's rewarding whenever, you have a chronic total occlusion of the SFA and other people have tried and they couldn't do it, and they come to you and you get it done quickly. It makes you feel good. But at the end of the day, I don't want to ever have to work on people. And so I especially tell people that after they've had a heart attack and I've met them for the first time. I say, okay, now we're at a stage where I know exactly what's going on in your heart. I put a stent in your LAD. Your circumflex has a 40% lesion. Your RCA has a 20% lesion. My job right now is to never, ever have to go inside of your coronary arteries again the rest of your life. And that's how I word it.
Yes. That's, people have to understand that. Well, actually, do you know that saying that good cardiologists, they can treat people, they can treat heart disease, but better cardiologists, they have to prevent the heart disease.
Yeah, absolutely.
Wow. Yes. Wow. Well, actually, what do you think about? Well, in the pandemic era, many people maybe deny themselves. I mean, they don't want to attend the emergency department or even go to hospital. I mean, we have the journal that say that STEMI and then non-STEMI visit is decreasing. So what happened there? Is there still? I mean, they're still.
It was very interesting what happened with us. I'm in Houston, Texas, so I can only speak on behalf of Houston, but I'm kind of familiar with what happened across the country too.
Yes.
Initially, when COVID hit and the world shut down, STEMIs declined and STEMIs declined. So everyone's like, well, what the hell happened to all the heart attacks? Just like you're saying, it was like, it almost didn't make sense. Like, people just stopped having heart attacks. And so a lot of people were questioning, like, why is this? Why are we seeing these numbers? And I never really got like a real explanation to, it happened because of this. I mean, of course, there's a lot of times where they call things NSTEMI when they're truly not NSTEMI. The troponin elevation is, honestly, I would give troponin elevation these days 50% chance. If I get a consult for a troponin elevation, half the time it's real, half the time it's not real. And when I say real, I mean that actually an infarction, right? I'm not talking an ischemia that would lead to a troponin supply-demand mismatch elevation. I'm talking actually an infarction where there's a ruptured plaque that is leading to a heart muscle telling us, help me, I'm not getting enough blood. And so, NSTEMIs went down, STEMIs went down. But then we also saw the flip side where everybody with COVID in the hospital was having coronary events, and they were real, Doc, too. These were not fake. I mean, and it was hard for us because initially, everybody was very scared of COVID. Now, to be honest, especially in Houston, Texas, we've learned to just live with it, and we're not as fearful of it as we used to be. And I think that same concept holds across the whole world. I mean, we were like, we can't bring a COVID positive patient down to the cath lab. He's going to infect everybody. And, it was like a big deal. But now we're seeing people with COVID, they are having this, the stress of it is the inflammatory response is leading to actual cardiac events. So it's interesting what COVID did with regards to the heart. And I still haven't figured it out, but these are just certain trends that we picked up on over here.
Yeah, increasing risk of thrombosis. And then we know that acute limb ischemia is increasing as well. I mean, there is a journal that in well, statistically, people with acute limb ischemia is more and more when it's affected by COVID-19. So before we go for that peripheral artery disease, that's very interesting part. What happened with telemedicine, and then what changing in USA in this pandemic era? Yeah, as well as telemedicine as well.
Initially, when the world shut down and all the clinics kind of, I don't think we ever shut down, but what we did is we went from 5 days working a week to 4 days working a week. And I think we did that for like a month. And we did a lot of televisits, and the government here, CMS, the Medicare, they allowed it. And then I believe the commercial insurances allowed it too. And so we were doing it quite a bit. We bought a bunch of iPads, and then we were sitting there, but it's not the same. Personally, I don't like it. There is some utility to it. I think what we should do with telemedicine, honestly, I think we should incorporate it into our everyday lives as physicians, because, you know, the patient doesn't want to come in. And for us, if we can relay information to them without actually having to see them, then why not, right? It makes sense, you know, like, but okay, for example, testing follow-up, and the testing is normal. It's great, you know, this way, because I like to explain the test to my patients, but I can explain it to them just like, you know, I'm talking to you now. I don't need to physically see them to explain to them test results. But then the question is, well, how do you know which tests are going to be positive? How do you know which tests are going to be negative? How do you know who to have a telemedicine follow-up with, who not to? So it becomes very tricky, in my opinion. The other thing is, you know, you can't listen to somebody with a stethoscope if they're at home. You know, how are you going to take their blood pressure? So, but I will tell you, I do like the concept of telemedicine. I like the concept of the ability of the physician to have more access to the patients and vice versa. I don't think that us as physicians should be limited to an office space, if that makes sense. Like if you and I want to start working from home and taking care of people from home, give us that ability to do that. The patients like it, we like it. There's nothing wrong with it, but it can't take over.
Yes.
Right? It cannot replace the office visit by any means, but we can use it as an adjunctive therapy, if you will. So there is a role for it. And in the US, by the way, it has become a huge industry now. You know, people kind of took it and rolled with it. And so there's a tremendous amount of telemedicine going on left and right. But not so much in the field of cardiology for obvious reasons. But in other fields like primary care and whatnot, it's become a huge thing.
Yes, well, there's a positive impact there, especially perhaps for controlling or follow-up hypertension, I mean, or dyslipidemia, but it's a simple thing. I mean, if you just met the patient and then you have to do a medical checkup, I mean, a heart checkup, I think you cannot replace the stethoscope. I mean, you cannot replace the palpation of the patient. You cannot replace the echocardiogram. So I think, well, it's depend on the situation. Well, I have a unique situation when the COVID struck down in March 2020, last year. So there's a patient with telemedicine. They asked me about how his dad. So his dad is complaining about chest pain, and then she got a video of that. And then, you know, it's actually a typical angina of infarction. I mean, well, it's really, you can hear them say just literally like in the book, you know, chest tight, and then it's like burning, and then it's sweating a lot, and then it's actually radiating to the left arm, and then it's already really like in the textbook. And then I think you have to go to emergency, and then it's not the case for telemedicine, right? You cannot do that.
Exactly. Yeah. So what happened? Did he go? What did you tell him? I mean, did they?
Yeah. Actually, that's a terrible thing, because I don't know, because it's telemedicine, right? So we just close the phone, and then okay, doc, we will think about that, and then they close, and then I don't know the news.
Right. So in the US, part of the problem of our healthcare system is that everybody errs on the side of caution, which is good and bad. Right. So there's this thing in the medical field in the United States. It's called CYA. You know what that stands for? You ever heard of this?
CYA?
Everybody in the US, everybody in the United States knows what CYA stands for. It means cover your ass. Okay, because here fear dominates how doctors practice. Fear of getting sued, fear of patients saying bad things about them or saying bad things to the nurse. You know what I'm saying? Fear dominates medicine, where love should dominate medicine. And that's where, back to what I was telling you guys initially about the humanity in it. I feel like you guys, based on what I've seen, what you guys are doing over there, it seems like there's more of that there than here. Honestly.
Wow. Thank you very much. Yeah. Well, actually, I can understand that. I can relate that, but because, well, you know that playing safe because of that fear of being sued, maybe, well, it's about trust, and then it's about actually many complex things. But I agree that we have to get a personal touch with the patient. I mean, get it trust, and then there is a communication within patient, and we cannot have it if we don't let the patient tell the story about them. Usually, like we get just really fast to the patient because so many cases, and then maybe we can miss that. I mean, the connection to the patient. So and
then you should see here how much you have to document. I mean, you literally, let's say in your average clinic visit, the way that they want us to do things here, which is the way we're forced to do things here, you end up spending more time in front of the computer than you do in front of the patient. And it's sad. It's sad, honestly. It's become sad. I mean, I always say this. The old doctors, when you think of an old doctor, I'm talking like 50 to 100 years ago. Nice, like sharply dressed, bow tie, smart man. If they saw the way that we practice now compared to how they practice, they'd be spinning in their graves. Honestly, that's how I feel.
Yes. One of my colleagues, well, actually, she just went for observership with me, and then he said that your work is like a paperwork. I mean, how do you do that? I mean, you see the patient, you examine the patient, you do characterization, and then after that, you will write down many of paperwork, and then it's actually like a case report, and then something like that, a summary. It's too long. I mean,
if you think about it, let's say you're doing like a diagnostic cath, right? The diagnostic cath doesn't take very long, but then you have to do all the documentation, the dictation, talk to the patient, talk to the family. That part takes way more longer than doing the cath. So it's becoming kind of silly, to be honest, how much paperwork and bureaucracy they're pushing on us. And unfortunately, Doc, it's only getting worse. It's not moving in the right direction. Every time there's a problem here, the solution to it is, we need to document better. And document better just means more time and work on the physicians, because ultimately all the responsibility falls on us. Nobody is going to protect the physician. Nobody. The hospital's not going to do it. The nurses aren't going to do it. Ultimately, it all falls on us. So anytime they want us to do more paperwork, again, it's just more work for us.
And then after doing that paperwork, you have to explain it to the patient and to their family. And then, it's well, actually, I think it's very tiring. I mean, if you have, imagine that if you have 20 patients a day, and then you can do it for how long? So that's why, again, my mission is to make it help the people to understand more about that. So I make it in social media. I make a YouTube. I mean, I recording the education, so they can watch it on and on. And I think you're in one frequency with me now.
For sure.
Yes. So okay. Another thing about that peripheral vascular disease in the COVID, we have problem is D-dimer, elevated D-dimer, and then it's actually being more renowned in the society. I mean, they are now keep checking D-dimer. I mean, after COVID-19, and then they check it more and more and more.
No, you should tell them to stop doing that. D-dimer, I am not a fan of. I never was a fan of it. BNP, to be honest, I'm barely a fan of that too. I think that you can make a clinical diagnosis without these massive sort of screening lab work like BNP and D-dimer. I don't think you necessarily need it. I mean, for example, D-dimer, right? Okay, so what are you worried about? PEDVT. Okay, well, let's look at everything else, right? Are they tachycardic? Are they hypoxic? Is their leg swollen? Is their leg painful? It's just look at other. I'm not saying not to check it once, but to continue checking it. That's not the right thing to do, in my opinion. I would never recommend that.
We are not trading numbers.
Exactly. That's the problem. Yeah.
And then, even when they want to have a faction, they ask me frequently, Doc, do I have to check my D-dimer before I get Moderna or before I get AstraZeneca?
No,
afraid about that.
No. That's terrible. That's all propaganda. I mean, I'm not saying that people did not get DVTs and PEs after the vaccine, because they definitely did. But this concept of making sure I don't have one before the vaccine, that's crazy.
So, okay, again, about peripheral vascular disease and then the relation with heart disease. So, I want to start to trigger the conversation, right? So,
sure.
I have a case that he have a first angina, and then turns out, long story short, he had one vessel disease, which is the LAD, and then no more angina, so he can walk longer. And after he walked longer and with longer duration, after that he feel the pain in the leg. So claudication comes up. So well, after that, we do PTA and the leg, and then after that he got to exercise and then more frequently, and then no more complaint. What about with the relation with PAD and heart disease?
Any of my patients that have coronary disease get screened. No matter what, I screen them. I screen them for peripheral disease, and if I have a strong suspicion, I'll screen them for carotid disease. But I also take the physical exam into consideration before just ordering tests. I'll check to see their pulses. I check the DP pulse and the PT pulse very well, the popliteal pulse, and you listen for bruits in the neck before thinking. But like I told you, when it comes to my patients, I want to know everything about them. It's almost like I want to have X-ray fluoroscopic vision without going in. And so the only way we can do that is by screening.
Yes.
And so I screen all of them. Like, if patient with 3 vessel disease, they'll get screened for sure, before the claudication symptoms arise. You know what I'm saying? Because I can tell you this about PVD. This is the problem about PVD. I love PVD, but I hate PVD. And the reason why is because, and you've seen this too, they don't complain. They don't complain until it's too late. You know how many people I've had that have CTOs, chronic total occlusions, and they never really complain that much. But then after you fix them, then they realize, oh my God, I was in really bad shape. The body gets used to this concept of claudication. It's not like the heart. When the heart is ischemic, it gives a really, really big signal like, hey, there's a problem, guys. Like, I need help bad. When the leg is ischemic, the leg is just kind of like this big, giant muscle group, and it really doesn't care because it's got a profunda to supply collaterals. And, as long as there's no wounds anywhere, people don't really care about it. They just think that maybe they're getting old and that their leg hurts because they're getting old, or it's arthritis, or, they just kind of tend to ignore these symptoms. But so that's why I hate it, because it's such an elusive disease, is what I tell people about PVD. And as much as I do, treating an SFA that's a 90% blockage versus 100% blockage is completely different. I mean, it makes the procedure so much more complex for us to deal with the 100% blockage. Because if there's a 90% blockage, I can get a wire to go through there. I mean, the wire will go. That's not hard to cross a 90% blockage. But when you're dealing with an area that's like fully concrete, now I have to take a wire, loop it, take a catheter, and I have to drill through there. And then I have to risk either perforating or going subintimal. That's a problem, So that's why it's almost about prevention, like we talked about too earlier with the heart.
Yeah, and prevention will be really more effective if they have awareness about that. Well, in Indonesia, we have a high rate of sedentary lifestyle. Many people in capital city in Jakarta, we have a sedentary lifestyle. They can just work in front of computer. Even more, we have bad traffic jam. About years ago, and then it's make people that sit down for long hours. And then when they feels that their leg cramp or pain, just like claudication intermittent, well, actually they stop walking after that because they think, okay, maybe I'm too old to walking, so they stop walking. That's why the people with PAD will have like asymptomatic. It's not asymptomatic. They just still they are just not walking again. That's why.
Right, exactly. Yeah, absolutely. That's why, we got to raise awareness, and I think eventually people understand, because coronary disease gets a lot of press, right? Peripheral vascular disease, nobody really even cares about it. It doesn't even get 10% of the press that the heart gets. You know what I'm saying?
Yes. Yeah,
sure.
When you have a chest pain, they will become very afraid. If you just have a cramp or pain in your leg, you just feel, okay, just massage me, and then it's become better.
Exactly.
But actually, they have to know that you already said it clear that actually there is a systemic disease. So when you have carotids, you want to make sure that you know everything about your patient, about your coronary, carotid, and then the peripheral artery. Well, actually, it's really a systematic disease. So atherosclerosis, actually, if that happen in your heart, to happen in your vascular disease after as well.
100%. So what I tell them too, I say atherosclerosis does not discriminate, is what I say. Discriminate meaning it doesn't pick and choose where it wants to go. It's either there or it's not there.
Okay. So and then interestingly, we have I told the people about work from home disease, become more obese, cholesterol high increasing, and then they have now the CFI, chronic fat insufficiency, too much sitting. So,
absolutely.
What do you tell me about that? I mean, what's
your experience people have to move. You have to move. That's what I tell people. They always talk about, because most of my patients actually, Doc, they're older. Because I'm plumber. I mean, most of my patients I've met some point throughout my career, where I've met them in the hospital and they've had an event, and most people that have had events are older in age, and older people don't move, and now you're seeing it with the younger people. They don't move. And so that's what I tell them. I say, you have to get your body circulating. And I don't care if you're walking or jogging or Stairmaster, just you have to move. And to be honest, moving not only is good for your body, it's good for your mind. People don't understand that. Your mind has to have movement. When you're sitting at home all day long, your mind starts to just shut down. You have to feed, you have to exercise your brain just as much as you have to exercise your body.
Yes, well, so it's just not have your cardiac pumping better, but it's actually made a good circulation to your brain. Well, actually, more than that, actually, we have we have a scientific center in the brain. I know, and then maybe our audience have to know about that too. So, well, actually, our dopamine will be rising, and when we our body,
and dopamine equates happiness. We know that for a fact. We know that dopamine. So same reason why my children are addicted to iPads and Fortnite and all that stuff. It's because the dopamine release. It's the same concept.
Yes. And actually, we can trigger the dopamine release by moving. Keep moving. Yeah. Well, so your message is keep your heart pumping, and then your legs still moving.
For sure.
Okay. Hey, Doc, I want to talk to you more, but I know that's actually your working time there.
No, I don't know. I have a case actually ready to go next door. But
thank you very much.
But it's okay. The timing was perfect, though. No, you guys are awesome. And again, I just want to leave you with this: keep up the great work. I'm really, really enjoying seeing all your content, seeing all your videos, and I just get a sense that you guys over there are really, really making a change in people's lives, and you're trying to educate the public in a way. And so my wish and my goal for your country is to educate the public in a way from now before it gets too late and too out of control like it is over here, if that makes sense. You guys are on the cutting edge of technology, and I want it to stay that way. I don't want the corruption that occurred in my system to occur in your system. I need the doctors over there to stick together and unite. That's the key. All the doctors listening here, you guys have to unite. When they separate us, we have no voice, we have no control. So you guys stay together, work with your local government, and keep it growing strong. Don't let what happened here happen over there.
Wow, that's a strong message. And then I love what you said about the compassion. I mean, human touch in the people, and then you want us to still doing it. Wow, thank you very much for your appreciation, Dr. Khalaf.
Thank you.
I hope we can see each other again virtually,
Yeah,
or
I
maybe
hope so
perhaps in person. I don't know.
Oh, I would love that. I would love that one day. I would love
Okay,
that.
Dr. Khalaf.
Okay.
See you next time. Thank you very much.
Dapatkan informasi medis langsung dari Doktervito dengan subscribe channel YouTube ini. Anda juga bisa membagikan semua informasi berharga di sini dengan cara share ke teman-teman atau kenalan Anda.